So today we're delighted to welcome Toby Hackmann from Leiden University Medical Centre. So thank you, Toby, for joining us today for this seminar. So Toby's a PhD student at Leiden University Medical Centre, and today he's going to be talking to us about using relative survival techniques for developing and validating clinical prediction models. So I will pass over to you, Toby, if you'd like to show your slides.
I will begin sharing them.
Yes.
Yes, it's working now. Nice. Great.
Yes, thank you.
Yes, so today I'll be sharing some of my work in leveraging these relative survival techniques for developing a clinical prediction model, specifically for the application of shared decision-making in advanced melanoma. So this is part of the 4D Picture project, which is your Horizon EU funded project, where the aim is to help cancer patients, their family and healthcare providers to better understand their options and support them in making choices about their treatment at different stages of diseases by drawing on European data. And we're part of Work Package 2, Data and Modeling, where we aim to develop prediction models. So this is a European project, so we have a collaborative research team. So we are, of course, mostly from the Leiden University Medical Center, and we have some collaborators that provide clinical input and also help us with data collection from the Oncological Institute in Ljubljana and the Danish Region Hovedstad Hospital and the CCIT there. And some of our collaborators are also at the Erasmus MC in Rotterdam. So on the statistical side, I am working together on this with my promoters, Ewout Steierberg and Lisbeth de Vrede from Leiden University Medical Center, and Ewout, of course, now at the University Medical Center in Utrecht. And we also have a great team of oncologists to provide us with clinical input. So the goal of this project is to develop a novel prediction model to support shared decision-making about the treatment for unresectable metastatic melanoma. And as a quick introduction on kind of the context, unresectable metastatic melanoma. Melanoma is a very aggressive type of skin cancer. This had an extremely poor prognosis before 2012 when novel treatments were introduced. And since then, these novel treatments have caused kind of a large improvement in overall survival for these patients. So this is from one of the earlier trials where they still compare chemotherapy with the blue line. And you can see that after 15 months, only a very small portion still survive. And back in the day, basically after 2 years, there was barely any survival. And with these novel treatments, patients actually have the chance to survive the disease. So for this prediction model, we use large amounts of data from the Netherlands, Denmark, and Slovenia. In total, we have 6,700 patients. And among these patients, we have 3,500 events. So we have quite a lot of data to work with here. And this prediction model is for adult patients with this unresectable melanoma that begin first-line systemic treatment with one of the three kind of treatments that they can really pick from. So that is anti-PD-1 therapy, ipi-nivo, and BRAF/MEK therapy for those with familiarity in the field. They have to get this treatment within 8 weeks of their first visit, because otherwise kind of the baseline data is quite outdated. And this has to be done in kind of a specialized melanoma center. And we kind of hypothesize that you can generalize this model to other high-income countries or countries with that level of hospital care that you see in the three countries where we get the data from. We have a large group of predictors from personal characteristics, such as age and sex, a lot of tumor characteristics from metastasis, LDH, which is a blood biomarker, kind of melanoma subtyping, some mutations that are relevant, and also general health status of the patients, such as their WHO or ECOG performance score and some comorbidities. And these are all taken at this first visit to an oncologist. Then the intended use for the model is at this first visit to a medical oncologist, where they get the choice between these three treatments. And then the two endpoints that we try to predict for these patients are their overall survival up to 5 years after the start of this treatment, and kind of the usual care after this first-line treatment choice, and the population mortality for a person of their age and sex. And I'll get to why we also think this is relevant in a little bit. So the following elements are kind of part of this model. So we have this overall survival part that we want to predict, and for this we will use or intend to use a Cox proportional hazards model. This is to make it nice and interpretable. We have quite a bit of control, and we can really check with our clinical collaborators to see if the model makes sense and if they find it valuable, insightful, things like that. Then we have these three treatment choices, and for this treatment to really, or for this model to give these patients a valid choice, this treatment effect or the contrast between these treatments has to have a causal interpretation and some relevant interactions to also make the choice different per patient where necessary. And finally, we want to include this background mortality to estimate this population mortality for them. This will also give them kind of a reference survival curve, which we believe will help them with decision making for their situation. Because, of course, this is very different for older patients compared to younger patients. And this will be the focus today. So this prediction with relative survival where we incorporate the population mortality into survival prediction. So why do we want to do this? So in general, older patients are more likely to die. This is kind of clear in almost every model, and age is usually one of the most important predictors of mortality. So here you can see that for patients 75 and older, let's get this, you can see that the mortality after 5 years is around close to 75% here. And for patients under 65, it's still quite high because melanoma is a very dangerous disease, but it's still below 60% here. So there's a big gap. But if we then look at kind of the causes of this, for patients over 75, a large amount of this increase is due to other cause mortality. It's around 27% other cause mortality and 44% melanoma-related mortality, whereas for patients under 65, most of the death can be attributed to the melanoma. And of course, this is not necessarily new. Competing risks are done more frequently. I think the Predict Breast Cancer model also does it very nicely. They use a cause-specific approach. So they model the overall hazard of mortality, and they split it into the hazard due to breast cancer and other causes, because they have the cause of death in their data sources. This does have a few challenges, especially in other situations. So the first one is that cause of death is not always collected. To be able to do this, you need to have cause of death data, which is not always the case. The second one, I think, is that cause of death is not always reliable. So there's multiple issues with this, that it's kind of hard sometimes to attribute a death to a specific cause. So doctors might disagree on the specific cause of death. And there's also a source that also showed that the cause of death coding in the Netherlands statistics was not always the same for people that had to fill in tabular data based on death certificates. So even kind of the attribution can change there. And also these competing risks give this overall survival rate, excluding deaths from breast cancer, kind of a difficult interpretation. So when you hover over this eye, they explain what this means in the Predict Breast. And there they say that the dashed line shows the expected survival rate if the breast cancer did not cause any death. It goes down over time because everyone's at risk of other causes of death. And the line is similar to the survival rate for women without breast cancer, but it applies to women who have had breast cancer but die of other unrelated causes. They do a really good job here of correctly specifying the interpretation of this. But I think this is a very difficult interpretation for a patient if they would read it. Because it's not the population mortality of other women of their age, but it's kind of what they estimated from the data. So if there's any kind of residual effect of this, it would also be included, a residual effect of having breast cancer. So another option compared to competing risks is using relative survival. So in cause-specific hazards, you estimate these causes both from the overall data, but here you get your data on overall hazard from one source. In our case, this is my melanoma data. Then the population mortality, you can get that from National Statistics Bureau, so Statistics Netherlands, or in the UK, the Office for National Statistics. And this excess hazard, which is kind of the difference between these two, is then estimated by your model. Now, relative survival methods kind of solve these challenges a little bit. So the cause of death is not always collected. It's kind of outsourced to these statistics bureaus that collect the population mortality for the whole country quite accurately in at least, I think, the Netherlands and I assume also the UK. And this can, of course, change per country. The cause of death is not always reliable. We kind of circumvent that by just attributing the excess death all to disease-related causes. So we just estimate how many more died than we would have expected, and we assume that those are the patients that died from our cause. And the interpretation could still be difficult, but we have multiple options to share with the patient on these causes of deaths that could solve it a bit. And I think a few of them are more straightforward, although not always more relevant. Now, there's an asterisk here because we do have a new assumption that we have to make when we use this method, and that is that the deaths due to our cause of interest are not a significant proportion of all deaths in the country. So in our example, that would be based on our melanoma patient data. We know that around 800, a little bit less than 800 patients are diagnosed with this condition each year. So even if we assume all of them died, around 170,000 people die each year in the Netherlands. So it's at most, it's 0.5% of the total deaths. It's probably less because not, of course, everyone will die from this. Now, if we compare this to, for example, all cancer, so around 45,000 people die each year in the Netherlands from all cancers. So this is over 25% of all deaths in the Netherlands. So, of course, we could not use this method to kind of estimate the excess hazard for cancer patients because their deaths are a very significant proportion of this overall population death. So these measures that make it maybe more interpretable, there are generally four that you have to keep in mind in relative survival. So that is the overall survival. This is just based on the overall hazard that you estimate. Quite easy. This is the same as in normal survival analysis. The second one that you often see is the crude mortality. This is also what I showed earlier from my data. This is you show the total curve of 1 minus the survival, and this you split this up into the deaths attributable to the population and the excess deaths. So these are the cause-specific mortality in the presence of competing risks. So these are similar to the cumulative incidence functions in competing risks analysis. And in this article by Poher-Permet, they are also coined the cumulative cause-specific mortality. So these are kind of your actual chances of dying from one of the two causes, considering that you also have the risk of dying from the other one. Then the third one is the net survival. This is kind of the survival by assuming that one of the two hazards is set to 0. So this is the survival in a hypothetical scenario where you can only die from one of the causes and not the other one. So this is what Predict uses for their deaths excluding cancer. So they just set the hazard, in their case, the excess hazard of cancer, they set it to 0. So you only have the other one remaining. So this is a very hypothetical survival rate, and it's not one that you actually observe, which makes the interpretation maybe a bit challenging. And then finally, there's the relative survival ratio, which is kind of how likely you are to survive as someone with this disease compared to a person in the regular population. So if your survival is half as high as that of the normal population, then you get a relative survival of 0.5. So that's also often used, I think, in benchmarking of centers. So how do these curves look? So overall survival, of course, it goes down nicely, and it terminates here at, I think, 67% mortality. And these are the crude mortality. So here the two curves, they add up to this 1- survival. So this is the actual kind of observed number of people that die from other causes or melanoma-related mortality. Then the net survival is the survival from melanoma if patients were kind of immune from dying from anything else. So if you could only die from melanoma, then around 50% would survive. And then the relative survival ratio is kind of the ratio between these two curves here. So that you can see that it is a bit lower than 50%. So patients with melanoma have about half of the survival probability of patients in the general population. Now, how do you fit one of these relative survival prediction models? So you model on this excess hazard scale. So we split up the hazard, overall hazard, into the population hazard and the excess hazard. And on this excess hazard, we have this Cox model, this proportional hazard model, and then we have a baseline excess hazard that we want to estimate. So when we assume our data is the event time, the event indicator, and some covariates, we assume that this event indicator is either due to population death or an excess death. If we know this split, then we know this excess death separately, and we can do cause-specific deaths on this delta excess. But we don't have these, so what is our solution? If we have this Cox model kind of already, and we know our population mortality from our external source, we can predict the probability that a death is excess, given that a patient has died at this event time, by kind of comparing their excess hazard prediction to their overall hazard, so the sum of their population hazard and their excess hazard prediction. And then we can plug in these probabilities that they have died into our Cox model, and then we can fit a weighted Cox model by the probability that our death is excess. Now, of course, this the Cox model is required here, and we require these estimated death indicators kind of to fit our model. So we fit this with an EM algorithm, and we specify initial values for our coefficients and our baseline hazard. And then we estimate these probabilities of death the first time, and then we iterate until we converge. So we iterate between estimating the probability that someone has died from excess causes with estimating our new updated Cox model. Now, so for example, if someone is quite young, their excess hazard is very low, and if they then have high predictors of cause-specific death, so of excess death, then we are very likely that their death is excess. Whereas for a very old person with very low risk factors for excess mortality, we can assume that maybe their probability that their death is excess is quite low, and it's more likely that they died due to population causes. So we use that one. Additionally, we can, of course, also include some predictors in this population hazard. We don't have to just do it in general, but very commonly you can include age and sex, at least, in the population hazard. Most life tables from countries have that. And in our model, we also have country as a predictor in this because we have separate life tables from the 3 countries. So what are some of the benefits of relative survival prediction? So one of those is that you can actually estimate the treatment effect on the correct scale, because it's, I think, in my opinion, it is a reasonable assumption to make that treatment will only affect the disease-related excess hazard. So basically, we could kind of treat a patient, we could treat their melanoma-related mortality, but we cannot treat this excess mortality part. So this is just something that their general age risk factors, we cannot treat that, or at least not with these same medications. So we assume that the treatment has no effect on the population hazard, and we can also assume that kind of any negative effect of the treatment on survival is also captured in this excess mortality. So if you get treated and then you die due to adverse events, this is also captured in the excess hazard because this is not something that a general person in the population is at risk for. And we can also illustrate this with a quick simulation of people between 50 and 90 years old. And we assume that there's a constant baseline excess hazard, which is equal to the mean hazard due to their population factors. And we can also model then a treatment with a hazard ratio of 0.5 on the excess hazard. And then, of course, quite obviously, if we fit the model according to relative survival, this is the true model, we get the true result across these simulations. So we get our correct treatment hazard ratio using the correct model, which is quite obvious. But both the adjusted and unadjusted Cox model get a treatment effect that is too low. So what could be the effect of this? That for many patients, we kind of underestimate the effect of treatment. But for older patients, we might overestimate the effect of treatment because it affects all of the hazards. And this is because we don't uncouple this age from the disease hazard. So age is, of course, always a very important predictor, but there's kind of two components to age on all deaths. That's kind of the general frailty of age, that old people are a lot more likely to die. We cannot treat this old age effect. And kind of due to that, we might expect old people to benefit a bit less from the treatment because they have this higher competing risk of other old age factors. Especially imagine someone 90 years old, which we see more frequently in the melanoma data. They're very likely to die from other causes anyway, so the effect of treatment on overall mortality might be lower. So there could also be a disease-specific age effect, and then you kind of have this interaction with age and disease. So then an older person is more likely to die than a young person with the same disease burden. This is what kind of the model assumes if you just have only a main effect of age in the Cox model. And in this case, what you will see is that old people benefit more from treatment because they have a higher overall hazard. So their baseline hazard times their age effect will be higher. Now, when we look at our simulated models and predict kind of the overall survival curves for a patient 50 years old and 90 years old, either treated or not, what stands out is that here the red lines are between the yellow lines. So the yellow lines are the relative survival prediction. So for a young person here, the untreated line is down here. That's the solid line. And then if they get treatment, their survival chances jump up. Because the yellow lines are outside the red lines, we see that the benefit for a 50-year-old from treatment is higher in our relative survival model than our Cox model. Now, for a 90-year-old, this is flipped. So the Cox model here has, of course, a lower prediction untreated. But if you treat this 90-year-old patient, they get more benefit from the treatment, also than the 50-year-old, according to the Cox model. Whereas the relative survival model, this benefit is actually smaller. And that's because there's a larger amount of kind of other cause hazard. So do you also see this in practice? This is a nice simulation, but these are results from the model that I fit. So we have 3 treatments here instead of 2. So if we look at a 50-year-old patient with some brain metastasis, you can see here kind of their population mortality curve. It's very low for a 50-year-old, of course, as we would expect. And we can see that there's a lot of benefit between the 3 different treatments. Because most of their hazard is excess, and we can treat that. Now, for an 85-year-old patient, we can actually see that there's over 60% chance that they die from other causes within 5 years. So now the gaps between the treatments are much smaller here. So we see that older patients have less benefit from treatment because of this large other cause mortality burden. In theory, you have a similar effect with sex because in the general population, men are more likely to die. So they could get less benefit from treatment because of this higher competing risks. And if you include it in a model, then you get the same kind of interaction with treatment. However, generally, the effect of sex is much smaller than of age. So you don't really see a big difference. So you can see here for a 6-year-old man, there's a bit higher population mortality, but you don't really see any resulting change in the treatment effect really, because the effect is not large enough. Another benefit from using these relative survival models is that in theory, there's more transportability to new settings, because you can kind of exchange this background mortality table. So of course you have your overall hazard, which is partly population hazard and partly this excess hazard model. For the excess hazards, we have to assume that this is the same in your old setting and your new setting. This has to be kind of transportable. But now we only have to assume that this is the same instead of that the overall hazard is the same, because you can exchange this population life tables with those in a new setting. So for example, my data is all from Denmark, Netherlands, and Slovenia, who have very similar mortality rates over the years, over the ages. And this is on the log scale, so we kind of exaggerate the differences here. And one interesting comparison might be the United States, where kind of the mortality for younger people is a lot higher, and for older people it's actually quite a bit lower. So we can maybe transport it to that new setting. However, I think this benefit is more theoretical than practical, because if this population hazard is different enough for this exchange of the population life table to actually matter, then it's very likely that your excess hazards model is also very unlikely to be the same. So in Denmark and the Netherlands, these countries are very similar. We cannot see any difference basically in the prediction for someone from Denmark and the Netherlands. It's almost the exact same. But maybe there's some more differences if we compare Denmark to Bulgaria, which is one of the countries in the EU with a slightly lower life expectancy. And we can see still very small differences, but it's still almost negligible. And we can also not really see that many differences between the overall survival between these two countries. Now, if you were to go to an even more different setting where there are more significant differences, maybe between European countries and countries in sub-Saharan Africa, but then you completely lose this assumption, in my opinion, that your excess hazards model is likely to be the same. So if this is a benefit that you can change the population table, it is unlikely that you can make this assumption that these are the same. Finally, so how does the model perform in general? Is the performance good of one of these relative survival models? So we perform model validation. So this is from one of the papers from Ewout Steyerberg about different types of validation. So internally we use cross-validation. But of course you want to use some good validation methods. They advocate using internal-external cross-validation instead of using fully external validation in your development, because otherwise it would be kind of wasteful for data. External validation is very valuable, but they advocate for this. So we also use internal-external cross-validation. We leave out one of the countries, but we switch the Dutch cohort. We split up into 4 categories because otherwise the model would not fit very nicely, because we would leave out too much of the data. So these are kind of our calibration results. So we can see that for the Danish cohorts at 2 years, it is quite well calibrated. We look at the discrimination. I'm not sure if it's readable. It's very small, even for me. We use the Antolini-C index because we need a time dependency index, because we cannot use it. Harrell-C and UNO-C, they assume kind of proportionality of the survival curve, and it's not necessarily proportional because we have the population hazard and the excess hazard are not necessarily always correctly proportional for 2 patients. So we have to use Antolini-C index for the overall discrimination. So we can see quite good performance in Denmark and also each of these Dutch cohorts. So we split them based on center, on their geographic location between the north and the south, and on kind of their status as a university medical center or non-university medical center, because these tend to get different types of patients. So for those cohorts, it's quite well calibrated. Slovenia, there's a bit of an inflation, and so we observe more deaths than we expect. And we can also see that already kind of in the data. So Slovenia has a higher event rate than the other countries in the data that we received. So this makes it a more difficult. So this is the one cohort where the calibration is quite a bit off. So I see that I'm actually nicely in time. So finally, I would want to thank the European Union for funding, and also we have a team in the UK that is funded by the UK Horizon program. And that is it for me.
Thank you, Toby. That was really interesting. I will open up to questions now in the room or online. Is there a question in the chat? No. Okay, so if anyone wants to put their hand up and they can ask a question online or add your question into the chat. We have Richard in the room who's got a question first.
Toby, that was brilliant. That was really brilliant talk, and very, very important. I really like the way you're separating out all these different aspects of prediction. I think it's really, really, really helpful to people who are trying to link this with treatment decision making and so forth. I hope this is something that we see more of in prediction world. My question is, would you see this as a I don't know what the question is really, but is it more to do with causality? So there's been a lot of push towards counterfactual prediction modeling, which often makes some strong assumptions. Whereas here I can see you're unpicking different aspects really well. So do you see this as a causal prediction modeling framework that's very transparent?
Yeah, so I want to say I'm not an expert on causal prediction modeling. So in Leiden we have Nan van Geloven for that, but we do use inverse probability of treatment weighting to kind of correctly estimate a causal treatment effect. But I do think that I would say here, I think it's also an important addition to consider kind of the scale on which you're modeling a treatment effect, because if you have very little excess hazard, then I think a correctly estimated causal treatment effect on the overall hazard is valid. But I do now also see issues that if you estimate it on the wrong scale, you get a causal effect on the wrong scale, which might still could still lead to wrong conclusions. So I wouldn't say this is kind of a replacement, but it could be interesting to look at this in the future as a possible addition.
Yeah,
I would leave it there. I'm not familiar enough to claim if it's necessary or not.
I was just thinking in terms of it, when you're looking at the impacts of a particular treatment on cancer, and you've got these other deaths from other reasons, you can look to see the actual change in the cancer prediction, specifically if the cancer treatment is being received. It might have that sort of still a causal sort of thing. And very quickly, my second question was about, should you be checking the calibration of all of these different submodels? You showed calibration at the end for some overall prediction, but Paul Lambert's group's done a lot of work on this as well, where you should be looking at the calibration of all the submodels as well, I think.
Yeah, so you mean that you look at the calibration of the population and the excess separately?
Yeah.
Yeah, so I think that it's difficult on the population side because you don't, if you don't have the cause of death data, you cannot really. I'm not sure if you can check if it is calibrated well on its own. And there's also one issue that I didn't highlight is it's kind of difficult what you do with the uncertainty, because we take these population life tables as having no uncertainty.
Yeah,
so the final prediction model does have uncertainty because of the excess hazard model and all the estimation going on in there. But it's also kind of a philosophical question if there is uncertainty in these population life tables. If you have the whole thing, you have every death in the country. is there uncertainty, but so we assume now that in the population hazards part, there's no uncertainty there.
Yeah. I'll let someone else ask a question.
Thank you. So we do have a few questions in the chat. The first one from Eslam, you are welcome to unmute yourself if you would like to ask the question yourself. Otherwise, I can read that out. No. Okay, so it says...
Hi.
Oh, yeah, sorry, go ahead.
Did you hear me? Sorry, I'm not sure. But I was just wondering if instead of using these brands, which you instead of contrasting with a population of survival, to do that, like assuming that the population is survival.
Sorry, I cannot hear you well enough.
Sorry, it's breaking up quite a bit. So I'll just read the question out from the chat instead. So it says, could a relative survival model be used to uncouple standard of care, TTT, and disease hazard from a new treatment? I assume the population hazard is standard disease, and we assume there are no competing risks and just any net survival is attributable to new treatment.
Oh, that's an interesting one. I think in theory that it could be possible, but I think it would be, it sounds like a more difficult problem. I think in theory it could be possible, but I'm not an expert enough in the details of the method to know whether that could be done. I would then refer to the experts who developed the methodology.
Thank you. We have Sophie. Would you like to unmute yourself, or I can read that out? So I'll start. So, how do you comment on the role of biomarker predictors? May not be available in every antenatal setting, particularly low-income settings, in the model's implementation and transportability.
Yeah, so I think that's where again this kind of comment on the issue with transportability came in. That so if the population mortality is so you need to assume that both the population mortality can be exchanged, and that the excess hazards model is the same between the two settings for it to apply to a new one. And I would also think so. The biomarkers that are used here are at least standard collected in European countries, which is also the development data from the model. If you would go to two low-income regions where they don't collect these, then I would also assume that the model would not be valid, just because we cannot assume that the excess hazards model is the same there. So I think regardless of if you collect these biomarkers there, you already would have a problem then just with the model in general. Which is also why I think earlier we specified that the model should be applied in kind of high-income hospital care settings. So many high-income countries would have these, and maybe also low-income countries where they have hospital care for some people of the correct quality. You could maybe use it, but so I would assume that if they don't collect it, I would not trust the model.
Thank you. So we have another question in the chat here from Diana, which says, would a multiplicative model be more robust than an additive for the population and excess hazards?
So you mean the? So I know that there's. So here we of course assume this. So this is an additive relative survival model because we add the population hazard to kind of the excess hazards model. And then on the excess hazards, we have this proportional hazards model that we assume. There are also multiplicative relative survival models where you multiply the population hazard by the excess hazard, which I think in some situations it would make sense. But I think here, so I think it was also in this plot. It's back here all the way. So here, of course, we test this in an additive relative survival sense, where we add kind of the other cause mortality to the melanoma. And we can, it seems to fit quite well that most of the difference between older and younger patients is caused by this additive effect of the melanoma, and the melanoma-related mortality is quite similar. So I think it looks like the additive relative survival model fits better here than a multiplicative model, because then you would expect the gap to inflate so that there would be even more other cause mortality for, or even much bigger melanoma mortality also on this side.
Thank you. Yeah, thank you from Diana there. Do we have any other questions in the room or online? If anyone wants to raise their hand online, please feel free to do so. In the meantime, I just had a question. So you'd said the cause of interest, cause of death of interest that you're looking at can't be a significant proportion of the all cause death. Is there a set amount that is there a set value, like a limit for that, or is that just more judgment?
No, I don't think there's a limit to it. I didn't see it also in the literature, but I think how I would visualize it is kind of that you would have an issue maybe with like double counting these deaths, both as excess and as population. So it also depends on the situation, how scared you are of that. So I would say that at least this 25% is too big. I would also consider at least like 10% much too big. So I would try and keep it under at least 1%, which I think for most sub diseases it would work probably. So of course, if you look at all cancer or all cardiovascular death, then it probably won't hold, and maybe the largest types of cancer it might not hold. But I think other than that, it will generally be quite safe.
Yeah. Okay. We just had another question in the chat as well, which says, would you consider a fine grained model for this kind of data?
No. I think in our department it's not very often used, the fine grained models, and I think they also have a problem that if you make survival predictions for multiple causes, they can add up to more than one. And I think that would be a problem there. So it might be that the probability to die from any cause is higher than one for a patient. And
Paul has his hand raised. If you would like to unmute yourself, Paul.
Yeah, hi. Well, first, thanks very much for a really interesting talk. I work a lot with sort of cancer registry data, where we're usually more interested in descriptive models. So my question is, in a prognostic model, you're probably modeling some sort of comorbidity information, and of course, the comorbidity information may also impact on other cause mortality, which you don't have in the population life table. So when we're doing, say, comparisons between population groups with different population mortality, such as socioeconomic groups, we know we get biased results if we don't, say, stratify by other cause, the population mortality caused by socioeconomic groups. So I wonder whether you run into problems or you don't run into problems in a sort of in a prediction model when you start to include many factors, which may include sort of other comorbidities.
Yeah, so if you include comorbidities, you can of course include them also on the excess model, but if you assume that they of course will also usually impact the background mortality. So a colleague of mine for my project at the Erasmus Medical Center is working on a project where she included kind of a third external data source to estimate the impact of a comorbidity index on all-cause mortality. and she included kind of that as a multiplicative effect on the background hazard, on the population hazard. So it can be done that you include those sources or those types of impacts on the population hazard from another source. Then you do get to where you certainly will have uncertainty in the population hazard. So I think you could do it that way. I'm not sure if you, so I think if you include it in the disease model, but not the population model, you could get into a similar kind of problem situation as you do with including age in the excess model, only by assuming it's not in the population side. So I'm not sure if it would make the problem worse, but I think you could deal with it if you have external knowledge on the impact of this comorbidity on the overall population hazard.
Okay, thank you.
Thank you. So do we have any other questions online? Does anyone have any in the room?
Just a quick one, Toby. Did you look at the clinical utility of the model in terms of net benefit or something like that?
Not yet. We are planning on doing that, but it was a bit more difficult to implement, so it wasn't the first thing we focused on. So the model choice was made based on scaled Brier score and kind of the calibration plots mostly from cross-validation. And we'll look at the clinical utility when, before we publish it, but it's also more difficult because, it's very much aimed at the shared decision-making side. So we do want to consider this clinical utility, but also for quite a wide range of risk thresholds, because it could differ a lot for patients from different cultural backgrounds, different ages.
Thank you.
Okay, thank you. So if we don't have any further questions, then before we do wrap up, I'd just like to say that we've got another TAP seminar on the 23rd of June at 11 AM, where we have Richard Riley here from the University of Birmingham, and he's going to be talking to us about the general sample size framework for developing or updating a predictive algorithm. And then the final TAP seminar of this academic year will be on the 14th of July at 1 PM with Willie Hamilton from the University of Exeter. And he will be talking about the ERICA trial, where they have been evaluating the effectiveness of a prediction model within a cluster trial. So if anyone would like to join either of those seminars, please do send me a message and I can add you to the invites. And before we finish, please can we all just thank Toby again for joining us today and giving such a brilliant talk. Thank you, Toby.
Thank you very much for inviting me. It was great to be here.
Thanks, Toby.
Thank you.